Kia ora koutou, and welcome to today's webinar on transforming healthcare interoperability with FHIR. I'm Rebecca Macbeth. I'm the media editor at HINZ, and I'll be your facilitator today. HINZ would like to thank InterSystems for sponsoring this webinar. So we have a fantastic lineup of speakers today. I'm going to ask each of the panel to just briefly introduce themselves, starting with Lee Donoghue. Kia ora, Lee.
Kia ora koutou. Ko Lee Donoghue, tauka ingoa. I'm Chief of Data and Digital at Health New Zealand.
Thanks, Lee. And Alistair Kenworthy.
Kia ora tātou. I'm Alistair Kenworthy. I'm the Group Manager of Data and Digital Standards at Health New Zealand.
Great. And Anna-Marie Scroggins.
Kia ora all. I'm Anna-Marie Scroggins. I work as a Product Manager in Sector Digital Channels within Data and Digital. I'm also a registered nurse.
Kia ora. And Kate Ebrill.
Hi everyone, I'm Kate Ebrill. I am the lead for SPARKed, which is Australia's National Fire Accelerator, and I'm from CSIRO, which is Australia's National Science Agency.
And we have Matt Valentine.
Kia ora tātou. I'm Matt Valentine. I'm an emergency medicine specialist and the Clinical Informatics Director, Information Flow.
Perfect. So we are going to have brief presentations from each of the panelists, and then I will open up the floor for questions. So please do keep those coming in via the 3 dots button in the bottom right-hand corner of this player. But first, we're going to have an introduction from Brian Biggs. He's Director, Customer Relations and Sales New Zealand at InterSystems. Kia ora, Brian.
Hey, thanks, Rebecca. Thanks for the opportunity to say a few words. I think this is the third year in a row that InterSystems have supported this webinar on FHIR, and we do that for a couple of reasons. Firstly, I think any opportunity to get the informatics community together is really key and one that we should support, especially in the current climate with all the changes going on. But more specifically around FHIR, it's really key to what we do here at InterSystems. We, at our heart, are a data company. We talk many times about the multi-billions of patients or records we have sitting in our technology, and we take a real responsibility to making that data open and accessible to whoever it is. We don't use it as an opportunity to build a moat around it. It's not our data, so we try and make it as open as we can, and FHIR plays a key role in that. I was lucky enough to spend last week in Indonesia at our Asian Healthcare Summit. It was a really inspiring trip. Some of the work those emerging health economies are doing is really special. Partly by necessity, I think. Indonesia has a population of almost 270 million people or patients, and trying to connect up all of that data in a coherent way without using FHIR and other standards, you'd have no chance. That they have a necessity there, and they've also used some legislation to help them. So I'm pretty keen to hear from the panel later on about whether we could take some learnings in this market. The other key takeaway from that trip was, and it wouldn't be a health webinar without talking about AI at some point, but how getting our data clean and healthy and interoperable really is the key foundation block for whatever AI is going to bring to us over the next few years. A little bit closer to home, I spoke last year about the work we're doing up at Auckland, implementing our TrackCare PAS. That project's going really well. I talked about the FHIR API that we put in front of TrackCare that enables any other system to connect easily with our PAS. Leveraging FHIR, it means it's much easier for any other system upstream to be able to connect to that in a standards-based approach, which means you don't have to come and learn our way of doing things. It's all standards, and that's had some really good adoption. I'm conscious though that I am preaching to the converted when it comes to FHIR probably, so there's a really strong panel coming in behind me, so I'm going to pass it back to you, Rebecca, and I'm keen to hear and learn as well.
Thanks so much, Brian, for that introduction. And yeah, we'll be keen to follow the go live of the TrackCare PAS later in the year. So first, we're going to hear from Lee Donoghue. Do remember to keep your questions coming in as well via the 3 dots button in the bottom right-hand corner of your screen. Take it away, Lee.
Kia ora, Rebecca, and thanks again for inviting us to join you at the HINZ eHealth webinar on health interoperability with FHIR. This is obviously a topic that I'm really passionate about, so really pleased to join you again. And thanks to InterSystems for sponsoring us. Brian, as you said, you're our partner working on the Tupuna Aroha, the Auckland PAS. Big go live coming up. It's one of our key initiatives. No pressure, mate. But we look forward to that. But today we're going to talk about vision and progress on interoperability in the health sector and how we're working with our Trans-Tasman partners to align and adopt international standards such as FHIR, the International Patient Summary, the Core Data for Interoperability, and SNOMED, all really important topics. I'm also going to speak to some of the questions and concerns that people have raised around where we go with interoperability post-HIRA. You know, the obvious thing is that the need for interoperability hasn't stopped or paused. The mission goes on. Interoperability is right at the heart of delivering patient-centred, joined-up care. We need it, as Brian said, to support data-driven decision-making and sector innovation. Solving the interoperability challenge is no easy task. There's no fast fix or silver bullet. We need to take a long-term view. We need to be committed. We need to press forward. It takes an enormous amount of collaboration, coordination, and commitment from all the stakeholders, all the parties, industry, government, providers, and patients, consumer organisations. We're in it together. We need to drive adoption, implementation of common standards, architectures, and governance frameworks. There is no easy route, and we need to stay the course. This is also one of the reasons that we're so committed to working with our friends across the ditch on a common approach. We're doing a number of practical initiatives to push forward in this area as a part of our national interoperability roadmap. Like Australia, this is framed around a set of sensible principles, open data, modularity, scalability, agility, and alignment with international best practices. To me, this is a really sensible and obvious path to take, but it's about shifting the game, and we can only shift the game by pulling together, which is why we are committed to working with all the parties to set standards that become a part of this framework, this solution. The Digital Services Hub was a core component of HIRA Tranche 1, and as folk know, it's a cloud-based platform that provides resources, tools, and documentation for developers to access and integrate to our APIs and our digital services. That digital service hub is up and continuing to operate. And through that hub, we've already delivered a number of FHIR APIs that allow different systems, applications to communicate and share data with minimal effort, minimal hassle. Key ones of those, which Anna-Marie and Matt will speak to a little bit later on, is the New Zealand e-prescription service API, which allows prescribers and dispensers to electronically send and receive prescriptions, and also the New Zealand immunisation API, enabling immunisation providers to record and access vaccination data. So, these are up, operating. We need to drive the wider adoption. I mean, they're really just the start. We're also building on the capabilities and the framework that's been delivered. And in some ways, this is almost opportunistically, but when different services come to us with a business problem, we're looking at how we solve it through the interoperability framework and infrastructure that we have now in place. A great example of this, and I'm really pleased to see, is the development and plan for the phased deployment of the National Rheumatic Fever Care Coordination Solution, which will come in 2025. And as I understand it, people who are mainly teenagers and children who have rheumatic fever have really complex health needs and need monthly injections to prevent recurrences and progression of the rheumatic heart disease. So having that coordination solution that allows providers to join up and provide access to those patient records is a key element of providing high quality care. And once we've fully rolled out, it'll help coordinate the monthly injections, improve patient recall, clinical data visibility, better care, which is a core objective for our public health services. Clearly, there's a little bit of an elephant in the room in terms of the pause, the HIRA pause that was announced in June. It does create some particular challenges and uncertainties for us. There's no way around this. We are looking at plans and engaging with the Minister around where we go with APIs and investment as a part of the 10-year infrastructure investment plan, which is being submitted in November this year. And the objective there is really to outline the investments and the roadmap that extend from this year forward. We are competing, obviously, with many other areas that are looking for capital investment, but this is where I hope by telling a strong story, we can justify why it is better to invest in digital than perhaps some buildings or other infrastructure. This is a key element of changing the standard of care. So we're very much still looking at how we move forward with the patient summary and a range of interoperability initiatives. It's obviously become a little bit tougher in the budgetary context, but we do have now the Digital Services Hub and a platform to build upon, and also the skills and I think the momentum that we've built up in the sector. So very, very keen to continue to push forward. We're also continuing the dialogue and the collaboration with Trans-Tasman counterparts, both the Australian Department of Health and Aged Care, the Australian Digital Health Agency and CSIRO as a part of that with the FHIR Accelerator. In July, we had Daniel McCabe and a group from across those organisations across. It was great to host them and run a major event at the Beehive. Certainly there was a lot of interest. I think we had twice as many attendees this year as we did last year. I guess digital health's been in the press, not always for the best reasons, but it's great to see the industry interest and desire to press forward. I mean, this collaboration is really, really critical to improving care, not just here within Aotearoa, but also looking at how we support care across boundaries, regionally, and then globally as well. We've also had a number of key events that we committed to last year have carried forward, so that the Ring of Fire Connectathon that was held in March, I thought was a great opportunity to get industry together and again push forward, share thinking, build skills, the implementers and the enthusiasts. And I want to thank Kate and your broader team, Kate, that have supported us on this work and this webinar that builds on last year. So it is very much about go forward. It's go forward clearly with some constraints and headwinds, but we are committed to this course. It's about pressing forward with interoperability, our vision of better connected care, raising the bar, raising the standards. I want to acknowledge and thank all the stakeholders, all the participants, all the enthusiasts, people who are a part of this movement for your innovation and effort that you bring to this task. We have to be creative, we have to persevere and drive forward. We will continue to work with the sector in the development of standards. We're also committed to continuing to keep people updated on where we are. Today, I think, is a great example of that, Rebecca, building on the seminar, and I look forward to questions and engaging the panel at the end. Back to you, Rebecca. Thanks.
Thank you, Lee, for that presentation. Yeah, and it'll be great to continue the conversation at Digital Health Week when we have an Australian delegation coming over again. But on that note, we are going to hear from Kate. Thanks, Kate.
Thanks so much, Rebecca, and thank you so much for inviting me along again. It is really great to be able to participate in this, and I participated in this webinar 12 months ago, and 12 months ago we were just kicking off Sparked, our FHIR Accelerator. Interoperability is a team sport, and I just want to confirm what Lee said. And we're very lucky that we have been kicked off 12 months ago. It was our birthday for Sparked last Friday on the 23rd of August, where Sparked was a national FHIR accelerator supported by the federal government, but really to do that bottom-up community development, and totally support what Lee said in terms of to actually make this work. It's government coming together with industry, with clinical organisations, with clinicians, with consumers, with experts to actually build and develop the standards that we need to support within our countries and to share information across our countries. The aim of the Sparked Accelerator was really to accelerate the use use of those national fire standards. I think one of the key things about Sparked is normally when we did a lot of standards work in Australia, it was like, we're building this thing, we're building a piece of infrastructure, and actually you've got to really rapidly, like in six weeks, maybe to 3 months if we're lucky, develop the standards. What we were given through Sparked was an opportunity to build a community, to accelerate the development of those standards, to ensure they're fit for purpose, and in parallel, and collaborate around what that national infrastructure should be. So by the time the design around the national infrastructure, looking at rolling out, we'd had significant time to support the development of the standards, the creation of those standards, test them out and ensure they were truly fit for purpose. So I encourage everyone listening to this call to say, actually now is the time to really focus, come together as a community and start working on those standards, because as the rest of the infrastructure plans unfold, it will mean that you'll come together and join up in a much better way than if we're rapidly as a standards community trying to keep up with the build of national infrastructure. So I think, I really encourage that everyone, as Lee has suggested, really gets involved in the development of the standards and ensure they are fit for purpose. So within Australia, the community it's funded through the Department of Health and Aged Care, the Australian Digital Health Agency, who's the national organisation responsible for the National Digital Health Strategy, which is developed on behalf of all governments, the National Interoperability Plan, and the Standards Action Plan against that. So also, since I last spoke to you all on this webinar 12 months ago, the Digital Health the Department of Health and Aged Care delivered the digital blueprint, which is the federal government's digital blueprint, and the Australian Digital Health Agency also released the updated National Digital Health Strategy, and is tracking actively against that interoperability plan. So I encourage any of you to seek out those documents on their websites. Importantly, because this is about standards, we're also delivering it in partnership with HL7 Australia, who's the SDO responsible for the fire standards, and I'm a director on the board of HL7 AU. Next slide, thanks. So the Sparked Accelerator was really about building those foundationals. So AU Core Data Set for Interoperability, AU CDI. There's a New Zealand one, I believe, also in development. And this is also building on work that's happened globally within the US around US CDI. Canada's developing a Canadian CDI. So it's important that, yes, we are localizing these standards for use within our own countries. We've got certain regulatory environments that we need to adhere to, certain cultural differences that we want to make sure that our standards support. But ultimately, at the end of the day, we're about leveraging those international standards, working globally, because our vendor network is largely a global network, but we also want to allow for industry that's developed out of our own countries to also be able to work globally. So it's important that we kind of look to leverage and collaborate around this work. And even more importantly, I agree with Lee, between Australia and New Zealand. So we're developing the AU Core Data Set for Interoperability, which is really what is that core common data that we require to have to exchange between systems. Importantly, yes, Fire Implementation Guide is how we exchange it. It's the technical way we exchange it. But importantly, that I say, unless we actually get the data quality right, we work with our clinical audiences, we work with consumers, and we agree what the important clinical data is, we are just pushing garbage data around faster. So for us, the fundamental piece is actually working around defining this core data set, getting that buy-in for everyone, ensuring it meets the needs of clinicians, it's consumer focused, and it also supports government policy, and it's easy and readily implementable by industry. If we can get those four aspects right, then we've actually got something that's going to be fit for purpose that we can build as our foundations. 12 months on from when I spoke to you, when we had just launched, we have now published AU Core R1, and we've also finished our eRequest data set for interoperability, which we're just finalising based on public feedback. Importantly, SNOMED and LOINC are key standards that fit within this. If we're talking about how we're exchanging information, we need that common language, which SNOMED provides us. And then we're also building the fire implementation guides to support this. So our AU Core fire implementation guide is just currently going through ballot, and our AU requesting guide is going through ballot for comment right now. One of the great things about fire is, for all of us who've been involved in lots of standards conversations over lots of years, it's a lot of sitting in rooms talking, debating, and producing some great documents at the end of it. One of the key things about FHIR is it's about truly piloting those standards as we go through things like connectathons, through things like we've been having testing workshops and building reference implementations, open source products that can actually be used. And everything that I'm talking about now is open. It's either available under the FHIR Creative Commons, where it comes to SNOMED value sets under SNOMED licensing, but New Zealand is also a member of SNOMED International, and all of our work around NZCDI is all publicly available, and all of the tools we're building is open source. So great opportunity to do what you do well, which is take some of our stuff, be inspired by it, improve on it, deliver something better, and hand it back to us that we can pick up and work on. Next slide, thank you. The scope drivers when we started AU-CDI and our AU core was really guided by what were the concepts for a health summary, but really focused around transfer of care, chronic disease management, decision support, that really basic core information. Next slide, thanks. One of the key principles around AU-CDI is a lot of the work that we've done around data standards in the past has been really driven by that secondary use population health data standard. Kind of ends up being tail wagging dog, where we need to define first what's the data that clinicians need. And I'm sure Matt will talk to this later today, and something that he's really passionate about. How do we make sure that the data is what clinicians need? If we get that right, data quality will improve. It's about what do clinicians need at the point of care? How does it drive their decisions? How does that information importantly need to be exchanged to the next person in the care chain so it supports their care for that individual as well? And importantly, back to the individual themselves so they can also manage their own care. So this isn't about data for data's sake. This is not about building national reporting standards. This is about defining the data that we need at the point of care, that we need to exchange at the point of care. And if we get that right, then, you know, there's a much more buy-in around how do we keep this right, maintain it so that we can exchange it. Next slide, thanks. Core of the core, a term that's been coined by one of our fabulous clinical co-leads, Dr. Chris Moy. When we're talking about the core, what's the core of the core? And you've got to all look at this and think, that's really boring, that's really basic. Absolutely. What is the core information that if we get right, actually supports 80% of every use case and 80% of what we want to do in our systems? But importantly, we wanted to get our first release of AU-CDI out in 6 months. We have a 2-year program. How can we, and this is an accelerator, so how do we rapidly define? And if we can get this core information right, be recorded in a quality way using terminology, using SNOMED CT within our systems, then this can actually drive the majority of the interactions that we want. So we started with that first core of the course so that when we went out to public comment earlier this year and we received over 50 submissions from government agencies, consumer organisations, clinical organisations and industry, what we wanted was everyone to say, yeah, of course, that's core of the core, but what about? And give us a very long backlog. And thankfully, that's exactly what's happened. Next slide, thank you. What happened in our federal budget this year, we were originally only funded for 12 months under the program, and it was planned to go back to budget next year if additional funding was received. However, due to the amazing work of the community that's come together, where we have over 700 individuals and organisations registered as part of SPARKed, we have over 400 individuals and organisations who participate actively in our clinical design groups, over 400 for each of our AU core, tech design group and eRequest type design group. And I know that many of you watching this are probably registered as part of that program, because we're very lucky to have support from industry from both sides who work across both countries. And the government said, hey, you know, we're getting traction here. This standards thing, you know, seems to be something where if we can actually truly bring the community together and work bottom up in hand with government coming in with policy top down, we actually, this seems to be a way to be able to move forward on our interoperability journey. So building on this, they asked us to actually look at how do we start to focus around that internationally consistent patient summary? How do we start to record the better ability for understanding reason for health encounters, which will get us a better idea of what's happening throughout the primary care healthcare system, and also look at how do we support chronic disease management that starts to feed into work around national electronic clinical decision support. So that really kind of focused us down for the next phase around AU Core R2, and in similar parallel our work around AU Core FHIR IG, and also now really looking at the AU Patient Summary Implementation Guide. Next slide, thanks. So now if we look at what we're looking at for AU CDI R2, which will feed into our next AU Core, and the FHIR IGs for patient summary, is how do we start to expand that out to include functional status, pregnancies, things that support chronic disease management around social determinants of health, social emotional wellbeing, and plan of care, and are looking to have by this time next year a FHIR IG that supports this, and AU CDI. Next slide, which I think is my final slide. How to get involved. Quickly onto that next slide. If we're going, yep, anyone is open and welcome to join these tech design groups. Everything is available online. We'll look for continuous feedback. And importantly, those connectathons, which Lee mentioned earlier, we're excited to come over and support any connectathons this year at Digital Health Week, but importantly, HL7 AU and HL7 NZ are planning for a follow-up joint connectathon in March next year in joint symposium. So I hope you all will enjoy that too. Thanks, everyone.
Thanks so much, Kate. We certainly look forward to seeing you in person again at Digital Health Week in December. So just a reminder to viewers, you can ask questions using the 3 dots button in the bottom right-hand corner of your screen, and we're keen to receive those, so please do. Next up, we have Alistair. Thanks, Alistair.
Kia ora, everybody. You might be feeling a bit of FOMO after Kate's presentation. Huge amount of stuff going on over the Tasman, but look, let me see if I can dispel some of that FOMO by talking about some of what we're doing here. So look, it's great to be on the podium with Kate and everybody today, and echoing Lee, we're working closer than ever with our Australian colleagues. Look, you might have noted, like I do, that at the Paris Olympics, New Zealand and Australia showed the rest how it's done in across several sports, and not least in the high jump events. So let's see if we can reach the same sort of heights in digital health as we did at the Olympics. So FHIR's the standard that started out life with the simple aim of just modernizing the way that we send and receive structured health data. However, since then it's become a galvanizing force and even a movement that's brought all our standards efforts together. So we now have a cohesive set of standards, a better set of standards than we have ever had before for high quality health data for interoperability. And I think more than ever, our health systems as a whole need this standards base to become truly productive and to better serve consumers. So this is just a bit of an opportunity to talk a little bit about the standards as a service offering that my team at Health NZ under the HISO banner offers. So first of all, FHIR. So we have published a first release of the New Zealand Patient Summary FHIR Implementation Guide that Anna Marie will be talking a little bit more about later. This is our fully conforming take on the International Patient Summary Standard, and the work here came out of the community efforts from our IPS-a-thon and Ring of Fire events with HL7 New Zealand. So the work is there on our website. It's there to play with, experiment with, and refine with us. So alongside FHIR is SNOMED CT. So you don't need to wrap a cold towel around your head to understand SNOMED. SNOMED is simply a system that gives a coded name to all medical conditions, interventions, and basically everything else in healthcare. SNOMED makes it possible to calculate personal health risk scores, choose health pathways, drive workflows, and do AI well. So SNOMED also plays well with activity-based costing. So my team at Health NZ operates the SNOMED National Release Centre, and we publish a 6-monthly SNOMED New Zealand release. Our edition is 99% the international edition. It'll be 99% the same as Australia's, but it adds the 1% of the DNA that reflects our unique health system and cultural requirements. We share our SNOMED authoring capability with accredited partners, some private, but mostly public. For example, Te Ahawa Te Kahu, the Cancer Control Agency, uses our release to publish SNOMED content for the world-leading CanShare program. We're also working in the private sector with Health Content Hub members to publish consumer-friendly terms using SNOMED for healthcare in New Zealand English and Te Reo Māori. In these efforts, everybody brings their own resources and the results are made freely available. That's our compact with them. Our most urgent to-do around standards is to complete the transition of primary care from the DOS era read code system, which served us well in the past, to the modern system, which is SNOMED CT. So to make it easy to use SNOMED, and to make it implementer friendly, we operate the New Zealand Health Terminology Service. It's basically a one-stop source of this standardized content. We update it monthly, and it's delivered via FHIR APIs. So please do visit the Digital Services Hub that Lee mentioned. To get an NZHTS API key, you can subscribe to the updates and download the latest content. There are also commercial and free and open source terminology service software solutions so that you can integrate this very closely with your applications if you're in the health software space. We do have a mini announcement, and so Kate, you talked about AUCDI. NZCDI is our version of the same thing. It's the brand new standard. We have it out for comment right now. In fact, this is kind of the launch of it. CDI stands for Core Data for Interoperability, and our standard puts data at the center. It's a multi-purpose standard and covers the absolute basics, such as defining the data elements that we need to represent core personal health information. Most of the definitions aren't new. They've existed in HISO standards for a long time. We're just bringing them out to make them a little bit more implementer friendly. We want to support conformance checking and adoption plans. Our NZCDI will have an annual update cycle. It's modeled, I guess, on not only AUCDI, but USCDI was the original. And USCDI is so influential in that jurisdiction that it's baked into regulations there now. So we will, Kate, my promise to you is that we will work closely with your jurisdiction on maintenance of our CDIs, because they are 99% the same. So we draw strength through partnership in our standards efforts, and we have all sorts of international connections. We work with HL7, we work with SNOMED International, we work with ISO and the World Health Organizations. These are all key forums. This is how we stay in touch with the international efforts around FHIR, SNOMED, IPS, CDI, and standards like CONSIS for continuity of care and OMOP for analytics. Through New Zealand's participation in the ISO Technical Committee for Health Informatics, ISO TC 215, we've contributed to the IPS version 2 and been influential in adding a couple of sections to that. And we now have a representative on the IPS maintenance agency. So I'm sending Kate away with a little bit of FOMO there, because I'm not sure Australia does. Anyhow, getting involved with these international forums means that we get to play our part in the international rules-based order as it pertains to health data standards. We also get to tell our story and get our requirements baked in up front. We are a member of the Global Digital Health Partnership alongside 40 other countries, and share and jumpstart materials for standards such as a global observatory of eHealth standards, which has just recently become available. Locally, we run some popular online events through the year, including the SNOMED NZ HISO and HISO Lab HISO. And in December, we will have a customary standards workshop at Digital Health Week NZ. This year, it's a SNOMED Working Bee. with Kiwi experts, and there's an invitation sitting in Kate's inbox for her to join us and be one of our experts. So thank you. That's all from me.
Thank you, Alistair. Just a reminder to viewers to keep the questions coming in via the 3 dots button. And if you did join a little late, you want to see information about the speaker panel, just select info. Next, we're going to hear from Anna Marie and Matt.
Kia ora, everyone. So look, it's been great to hear about the standards, to hear about FHIR. I want to just touch on some of the great things we've done throughout Te Whatu Ora in other areas to take those standards and make a difference to frontline healthcare and to consumer choice. Sorry, just needing to get people have chatted about the Digital Services Hub, but just another little plug. This is a place where we can go as a front door to find out about our APIs, but also importantly, API standards that were collaboratively developed and other tooling to ensure that we can participate in the ecosystem of development of data and information services. So Lee touched on the Aotearoa Immunisation Register API, and I just want to talk about, we do technology to support business outcomes. So a key health target for New Zealand is to improve our immunisation rate. One of the key initiatives have been the launch of the new Aotearoa Immunisation Register last year that included a full FHIR API that enables an ecosystem response to new care models that will improve the way people can view immunisation history and can administer medication, immunisations in the system they're using to do their job. So the eHealth API will provide that full immunisation history, and healthcare providers can create and update an immunisation record. So through the provision of this eHealth API, we're now working with our digital supplier community and our healthcare providers to enable new models of care, such as pharmacist workforce expansions, to allow for them to opportunistically screen and immunise in the community, a role that might have been traditionally done in primary care practice or public health outreach. Health consumers can view immunisation records within My Health Record and their children under 12. And we're supporting that opportunistic immunisation within a secondary care setting by integration of the eHealth API within our regional clinical portals. Another key area where we're looking to support public health is by delivering a FHIR API for our cervical screening summary. So that's taking that vital screening data from our national register and making it available to primary care screen takers, haora providers, sexual health Aotearoa, and other specialists involved in care. Cervical screening has moved to a primary HPV screening model that has been a fundamental difference in reducing inequities we've seen in our Pacifica and Māori communities. So by supporting information access to our primary care screen takers and others, it enables choice for wahine and participants around where they choose to get screened, and it will support the move to HPV and other screening models. We're now on to talking about a patient summary, and I'm going to hand over to Matt Valentine to touch on this.
Thanks, Anna Marie. Thank you for the opportunity to talk about this. I just want to start by mentioning, talking a little bit about the concept of a patient summary, just so we're not, sometimes all of us, myself included, sometimes have a desire to project all our hopes and dreams onto one particular thing, and it gets out of and then we don't have alignment and agreement. But specifically around the summary for a health summary, and Kate touched on this a little bit with the content, and we'll compare that to ours in a moment. But it's just the information, the very basic information about someone that a clinician needs to provide care for them, especially when there's not a complete record in whatever system that clinician is using, and perhaps even more important than that is provide sort of pointers as to where more information might be found if it becomes necessary. But in addition to that benefit for professionals, if you can make it as available to health consumers, then the several other advantages open up, and both engaging the consumer and their family and whānau in care and health and well-being, but also making it a transportable way to take your health information around. Kiwis are great travelers, and to Australia, to the islands, around the world, and so that ability to take your information with you without it having being specific to a particular clinical specialty or a particular disease is really, really helpful. Can I have the next slide, Anna-Marie? So the way that one of the ways that we're looking to do this in New Zealand is with the New Zealand patient summary that Alistair talked about, and all the work that went into that. And look, just to acknowledge for a moment what Lee said, although this was definitely something that HIRA has been done a lot of work on. The HIRA project did a lot of work on, and is hibernated now. The mission goes on, like Lee said. The needs are still there, the benefits are still there, and this is what we'll continue to advocate and work towards. But like the Australian patient summary that Kate described, you can look at the composition of the New Zealand patient summary here, and look, it's really, really similar. It's not sexy or exciting or wild or anything like that, but it just really reflects both the how straightforward the information that's necessary to do basic quality care for people. But that our systems don't always deliver that reliably. And like Alistair said, there was feedback to the gathered for the country to make it particular for New Zealand. And the use cases that some of that identified is nothing that again you'd be surprised by. There's the unplanned first encounter, which is basically all your emergency and urgent care. That can be for in the ambulance, in telehealth, in urgent and emergency cares. It can also be, though, to make sure that in planned encounters that all information is available and where more information may be found, and even somewhat surprisingly, in any sort of return encounters or continued care. We have our health consumers have a wide variety of places to get care, and so seeing some keeping track of what has happened since the previous encounter is very, very useful to delivering ongoing quality care. And one other use case I'll just mention real quick. One other use case that we were looking at, maybe a little specific to New Zealand, and it's kind of an unplanned first encounter, but odds are, if a coroner is looking at your record, it was probably unplanned, at least on your part, that you would need a coroner to review your records. But in New Zealand, where GPs are often called upon at odd hours to speak with coroners around whether a death was expected or not, and the disruption that causes to their and their families' lives, we've identified that the coroners having access to this sort of record would be particularly useful to help in their work. So a really wide spectrum of use cases that have been identified. I'll stop there so we have time for questions. So back to you, Rebecca.
Thank you, Matt. So we do have some questions coming in. Thank you for those, and you can still ask questions using the 3 dots button in the bottom right-hand corner of this player. The first one is around, are we considering Indigenous population health and not just Western medicine in the way that we've always done when we're looking at developing and implementing standards? I know this was something that was has been discussed previously. Kate or Lee, if you want to lead us off on that one.
Yeah, I'm happy to jump in first, because it's a really important question, something that we're really conscious of with the work that we're doing around AUCDI. And we wanted to make sure that, given that a lot of our consultation was just happening up and down the east coast of Australia, that we actually started looking at having focused health equity roundtables in rural and remote areas. And we recently held one within Darwin and had our College of Rural and Remote Medicine, our National Aboriginal Community Controlled Healthcare Organisations, our HISOs and consumers in the room. And what was demonstrated through that, and so important, and why we need to continue to do workshops in this way, is We ran a similar exercise that we did in Sydney, where we asked what were the priorities around the focus for the backlog of AUCDI. We held the same workshop within Darwin with the broader group there. What came out top in Sydney were things around diagnostic reports and more work around problem and diagnosis and devices. And what came out top when we ran the workshop in Darwin was a real focus around social emotional wellbeing, social determinants of health, care teams, care planning. And we were not surprised. We expected and hoped for that, and we're very pleased. But it really demonstrated the importance to make sure that you need to get out of the capital cities. You need to make sure that you really target all of the different consumer groups and healthcare groups to get that information, so that now we can build a backlog that's representative. So yes, we are, and it's really important because the results do vary and show that we need to really holistically and think about this from a broad representative point of view.
Just to build upon that, you know, I concur. I mean, I think we're starting with the core of the core, but we need to think more holistically. I mean, I was really struck traveling up to Northland by, I guess, a couple of things. One was, as you said, Kate, you know, extending across to a more holistic care approach versus purely medical care, and the need to, you know, extend across into social care and other domains, and think about moving towards a care record versus a more traditional patient summary care record. So I do think that'll be part of the evolution. But the other thing that struck me from Northland, and this I've probably seen here more in New Zealand than Australia, is the further you go from Wellington, the more community takes health care or care into its own hands. So some of the innovation that happens at the corners of the country, you know, in the far north or the far east or the south of New Zealand, where you're seeing community providers. And a part of this, I think, is to provide the platforms that enable care innovation and empowering not only consumer and whānau, but community providers to provide more joined up care. And I think this has to be at the heart of the vision of improving care. But also, I also want to acknowledge that not all these problems be solved by interoperability. A lot of our issues here in New Zealand are around access, a lot of the inequities. So there are broader elements as well that we need to be a part of as a more holistic response. Great question.
Yeah, and just building on that, another question asked here is about what support is there for implementers of HL7. They say trying to use this stuff in actual applications is very weighty. Are there libraries, class files, guides? My experience is that developers have to try and understand the standards and write it into usable application code. Alistair, that might be one for you to jump in on, is it?
Yeah, I mean, I mentioned standards as a service. So we have a team at Health NZ who's very happy to sit down with suppliers and talk about what materials are available to make it easier to implement the standards. Yes, there are libraries. There are a whole heap of libraries around FHIR. There are a whole heap of materials around SNOMED too, and we provide free SNOMED education as part of SNOMED International. So I think Rebecca, it's a matter of linking people up with those resources and dispelling some of the mysteries.
And I think if I can just jump in, one of the great things is FHIR being a global standard. There's a global FHIR community. So those that aren't familiar with chat.fhir.org, the Zulip channel, get familiar with it. It's 24-hour support online, because globally, somewhere around the world is working at some point and is there to answer questions. And it's a really open, vibrant community where everyone is there to really try and support each other. So absolutely reach out to Alistair and the team at Te Whātua, and there'll be a lot of support there. But yeah, look for all the open source products, join the global community, ask the questions. There's someone already out there who's trying to solve that same problem and is more than happy to help shortcut your way through it.
And you can probably even speak to Graham Grieve, right?
Absolutely.
the godfather of FHIR himself. Great, we'll just move on because this one is related to that as well. It might be one for you, Anna Marie or Matt. I don't know how much you'll be able to say, but these are related to the screening FHIR API. Just saying, do you have a view of when these APIs might actually be deployed? They're great, but it costs money to implement in a time when things are being paused. What kind of priority do we think these sorts of initiatives have?
Yeah, so the Aotearoa immunisation API is live. We've got applications using it and starting to develop those workflows to respond to our health community needs. The screening summary API, we're looking for last quarter for it to be live. It's already developed. We're actually working right now with 4 early implementers to support that adoption of that API. So we know we've got Industry, MedTech, Profile in My Practice, developing functionality now. The beauty of FHIR is through that implementation guide and some of the tools and processes set up in the Digital Services Hub, like test suites and sandpit environments, they're getting in there, and even while the API is not formally released, we're able to have co-development in parallel. So we expect when we release that to the Digital Services Hub at the end of the year, we've already got the development in flight with several of those early adopters. So that is very much a clear coming soon. The other thing I just want to touch on, within the Digital Services Hub, those API standards really support development effort. And there's also a knowledge hub. There is a community functionality. So as our API subscribers are coming in and using API, we've got the tooling, we've got the community set up for developers to give each other advice and share as they're starting to use these national services.
Great, thank you, Anna Marie. This one, it says it's a question for Alistair, but someone else might want to jump in. So they're talking about rare disorders, saying the recent 2024 strategy says that national health data sets will be available to routinely collect rare disorder information. So they're asking, around how do we collect general and including unknown or unspecified codes might need to be considered for interim use, where more specific categories are not yet available or do not apply. Is this on the radar, and over what period of time do you see this as being achievable for New Zealand?
Well, I think the beauty of these international standards like SNOMED that we've adopted is that they're effectively open-ended, and they do cover all those rare disorders. So I've spoken to the Chief Exec of Rare Disorders New Zealand, and discussed what the prospects are for managing that cohort of people who have these disorders, often young people, and it's really in primary care we need to be able to support these things as much as with specialists. So look, again, I'd come back to the thing of primary care needs to rapidly embrace SNOMED so that we can cater to these I won't call them edge cases, but these sort of more specialised cases.
Just one comment to add on the back of that is, there are some areas that we're not going to be able to move forward at the same pace because of our fiscal context across here. So part of the rare childhood disorders is genomics and precision medicine, and this is part of the reason for continuing and deepening the collaboration with Australia. Australia is obviously investing quite heavily in genomics and precision health, and so some areas are likely to move forward faster. We need to tie our tugboat to the back of the big ship if they're moving forward in some areas, and I think there'll be other areas where New Zealand can take a lead. It's a team sport.
Thank you, Lee. And another one is directed your way, but again, others might want to jump in. They just said there, particularly they're from a PHO, particularly interested in the Trans-Tasman collaboration, how we can continue to bridge the gap between primary and secondary care sectors as it relates to knowledge and process. Is there any opportunity to connect PHOs with PHNs to push forward shared thinking and learnings?
Look, it's a great idea, and that's probably, Kate, one for us to pick up with Daniel McCabe. One of the beauties of Dan McCabe, who is the Australian Department of Health and Ageing, is he also supports Medicare in Australia. So he's got a very strong interest in what happens in primary care. So we have had some broader discussions around, there are common challenges we have around strengthening primary care. Absolutely. I think that's a great suggestion. There are a whole bunch of common interests. And the other area around, primary and secondary care is, many people would remember Zoran from his time across in New Zealand, and Zoran's gone across to head up an agency that will be charged with bringing together primary data nationally from PHNs as a core element to start to join up primary and secondary data in Australia. It's something I'm really passionate about as well. Strengthening the links between primary and secondary care is key to, we're on a big data journey. So great suggestion. Let's pick it up with the Australians when they're back in November.
Absolutely. And I'm actually presenting at the National Primary Care Conference, the HN Conference, on Tuesday next week in Canberra. So it's something that I can throw out on the table to that group when I'm there. And part of that is talking about that joining up also of primary care data to secondary care data, Lee. So yeah, very timely.
Great. Always good to make those connections. This is rolls on from that actually, Kate. Do you have any tips from Australia on nudging primary care into adopting health standards, GPs in particular, as is unlikely to be a top priority for them? Working through peak bodies, working with the vendors, like the patient management systems, mandating standards through regulation or procurement commissioning?
Yeah, all of the above. So actually our Sparked program, as I mentioned, there's over 400 people who are part of the clinical data design group, and that includes our clinical peak colleges as well as individual GPs, allied health, hospital clinicians, and all of the industry. So that's where it's truly, coming together to agree that these are standards, because we should be, what we're doing should be making life easier, making doing the right thing the easiest thing to do, not adding extra burden. So if we can get these data standards right, we can make it a enjoyable experience within their information systems. And there's, I think there's a lot of benefit where some of the advantages that FHIR brings, we talk a lot about FHIR for exchange, but the two most exciting things for FHIR for me is things around Smart on FHIR and Smart Forms, FHIR questionnaires, and also clinical decision support. So if we think about, how many forms do clinicians have to re-enter that data in time and time and time again? If we can start to look at things like FHIR questionnaires, which are fully integrated within the workflow of the clinician, the data is pre-populated into that form and that data is able to be exchanged, and focus around reducing the burden of effort. And that's where we focus around our data. What do you need in your system to make it easier for you so that data can be reused? How do you build it once so the vendors can actually build on it as well? So single provision of data, multiple reuse, single build by vendors, multiple reuse. And that's really kind of the key themes. And, if we can focus and make it easier for clinicians, then of course it makes it easier to keep that data right. And, Brian mentioned this right back at the beginning when he introduced us, that also where AI is coming to start to look at things like ambient tech. How can we take ambient technology, make sure that we can safely and in a quality way turn that voice to text to code? That's how we can also look at how do we reduce the burn in that way. So I think, exciting times ahead, but we need you guys at the table, all primary care physicians and vendors at the table helping us design these standards so we can get there.
I'm going to add to that, Matt or Anna Marie. I know you're not a GP, Matt, but in terms of nudging clinicians, how do we make the case to clinicians that this is worth their time and resource?
Oh, I just want to agree with Kate that getting the standards right is the first half of that journey, and then the co-design with the clinicians is really the final hurdle to make it right. You can have the best standard in the world, but if it's implemented in a clunky manner, and it becomes a barrier to somebody's busy schedule, then it won't be adopted. But when we can both display the benefit, save the work with the multiple the reuse of the data like Kate mentioned, and make that data sort of a byproduct of the normal clinical workflow rather than an additional task, then I think that the clinical buy-in will be easy. But it takes that it'll take a concerted effort of co-design to make that happen.
Yeah, and I think the last point, so I think co-design usability, there's some really good lessons learned about how to make SNOMED coding part of the natural workflow. But I also think, primary care are also wanting to be users of shared data. So when we looked at the New Zealand patient summary, primary care is a key stakeholder group who wants to use it. So when you make data available to people and they need to use it in their workflow, the importance of that data, of the data quality, of the reliance on that data, that becomes really evident to them too. So there's part of, standards, vendors, co-design, but it's also about showing people and making it available and seeing the impacts of when workarounds are made and how that kind of stops our joined up efforts. So it kind of makes them part of the solution as well when you can make it visible to people.
Great, thank you, Anna Marie. And it's been a great discussion, and I'd love to keep it going, but unfortunately we do have to wrap it up there. So thank you so much to our fantastic panelists and to our sponsor InterSystems for making this possible, and to our lovely viewers for joining us today, for all your questions and for supporting HINZ. If you're not already a member, you can click on the HINZ logo at the top left of your screen, or you can go to hinz.org.nz, and we hope to see you next time. Mā te wā.